Welcome to the Explainer. For this episode, we're doing something a little different. We're going to simulate a high-pressure surgical board exam, what's known as the viva. I'll be playing both the examiner and the candidate to walk you through a classic life-or-death emergency, the ruptured abdominal aortic aneurysm. All right, let's jump right in.
As examiner, a 68-year-old male presents to the ER with sudden onset, severe back pain, and a systolic pressure of 90. How do you proceed?
Okay, so my immediate thought is that this patient is an extremist. We're very likely dealing with a vascular catastrophe. You know, that combination, the severe sudden back pain and the hypotension in an older male is highly suggestive of a ruptured abdominal aortic aneurysm, or AAA, until I can prove it's something else. I'm treating this as a surgical emergency from the absolute moment of presentation.
Good. What is the classic presentation you would be looking for on physical examination?
As candidate, I would be looking for the classic triad of a ruptured AAA. That consists of three key things. Number one, hypotension, which this patient already has. Number two, severe abdominal or back pain. And number three, the real telltale sign, if you can find it, a pulsatile abdominal mass on examination.
And the reason this is just so critical is the mortality rate. For a ruptured AAA, it is absolutely staggering. We're talking 80 to 90%. In fact, about 2/3 of these patients die before they even make it to the hospital. Time is, without a doubt, the single most important factor for survival.
Precisely. So what are your immediate management priorities right now in the emergency department?
Right. My priorities are all about stabilizing the patient just enough while we get ready for the definitive fix. We start by securing large-bore IV access. We need big lines for rapid resuscitation. Then, and this is crucial, we institute something called permissive hypotension to keep from making the bleeding worse. We also try to hold off on intubation because the anesthetic can tank their blood pressure. For any unstable patients, there's only one destination, the operating room, and we go there directly.
Permissive hypotension is really all about walking a tightrope. You see, most patients who actually make it to the hospital have what we call a contained rupture. That means a retroperitoneal hematoma is basically putting pressure on the bleed and holding it in check. So we give just enough fluid to keep their systolic blood pressure between 80 and 100. This keeps the vital organs perfused, but it doesn't raise the pressure so much that we risk blowing off that life-saving clot and causing a catastrophic hemorrhage.
Very good. A CT scan confirms a large AAA with a retroperitoneal hematoma. Now we get to the core decision.
You are in the operating room. Do you proceed with open surgery or endovascular aneurysm repair, also known as EVAR? Justify your choice.
So this is the central question. And honestly, the choice is complex. It really depends on a few things: how stable the patient is, the specific anatomy of their aneurysm, and what our hospital is good at. Open repair is the traditional gold standard, no question. But EVAR has some pretty significant advantages. A stable patient with the right anatomy at a center that does a lot of endovascular work, they might be a great candidate for EVAR. An unstable patient, though, or one with tricky anatomy, they're almost certainly getting an open repair.
Now, what's really fascinating here is this idea of abdominal tamponade. The biggest advantage of EVAR is that we can fix the aneurysm from inside the vessel, just using access from the groin. This lets us avoid a massive incision into the abdomen. Why does that matter? Well, that big incision would release the pressure from that contained hematoma, which could cause a sudden and profound circulatory collapse. EVAR actually preserves that natural tamponade.
Good. Let's say you decide to proceed with an open repair. Describe your key intraoperative principles.
As candidate, for an open repair, the sequence of events is absolutely vital. First, the patient is fully prepped and draped before we intubate them. The anesthetic drugs can cause their blood pressure to plummet, so the surgical team has to be ready to cut immediately. We make a long midline incision, get into the abdomen, and gain supraceliac aortic control. That means clamping the aorta high up to stop the bleeding. The goal from there is to minimize this clamp time to prevent organ damage, and then perform the simplest, quickest repair possible, which is usually a tube graft.
Okay, let's switch back to EVAR. What's a common complication that's specific to this procedure and requires long-term surveillance?
As candidate, the most common long-term problem specific to EVAR is something called an endoleak. This is when blood is still finding a way to flow into the aneurysm sac, even though the stent graft is in place. This keeps the sac pressurized and at risk of rupture. There are 5 main types. Type 1 is a bad seal at the top or bottom of the graft. Type 2 is retrograde flow from smaller branch vessels backfilling the sac. Type 3 is a defect in the graft itself, like a tear. Type 4 is porosity of the graft material. And type 5, which we call endotension, is when the sac stays pressurized even though we can't see an obvious leak.
This surgery is over. The patient is in the ICU. What major complications are you most concerned about now?
Well, this operation is just a massive physiological hit to the body, so we're anticipating multi-system problems. We're on high alert for a heart attack or myocardial infarction. We're watching for acute renal failure, either from the initial low blood pressure or the clamp time. Respiratory failure is also common. Then there are problems more specific to the operation itself. We're watching closely for ischemic colitis, coagulopathy from a massive transfusion, abdominal compartment syndrome, and of course a truly devastating graft infection.
Excellent. Your patient recovers and is eventually discharged. Let's wrap this up by shifting from this acute emergency to the principles of preventative care.
What is the single most important predictor of rupture risk that we screen for in patients who are asymptomatic?
Oh, without a doubt, it's the aneurysm's size, specifically its maximum diameter. That one single measurement is the most powerful predictor we have for the risk of a future rupture.
And this slide here perfectly illustrates the entire foundation of our screening programs. The risk of rupture is directly correlated with the aneurysm's diameter. Because of that, our surveillance intervals are based entirely on size. So, for a small aneurysm under 3 centimeters, we might rescan in 5 years. But as it gets bigger and approaches that 5.5 centimeter threshold where we consider elective repair, we shorten that interval, first to every 12 months and then to every 6 months. This allows us to step in electively and prevent the very catastrophe we've just spent all this time discussing, and ultimately save lives.